Thank you. I never was a politician. I just took the wrong decision in 2009 to go into politics, just when the budget was going into crisis. Not the right time, so don't become minister, land or national at the wrong time. I'm going to talk a little bit about, mainly about scaling up and the change management stuff. I think most people, just on the time question, which I think is very important, most people are finding just about everything is against these changes. So it's more than a question of time and of going fast. It's going to be, let's say, whether one gets the confidence of the patients and especially the providers back into these changes. Where you do get some providers involved, then it starts moving and snowballing quite quickly. Now, I'm saying the Basque Country, as you know, is one of the landers there. Two big cities, Bilbao, San Sebastian, Vitoria, about 2.3 million, a whole bunch of health centers and hospitals. But what I wanted to indicate is it's a very tidy system, apparently. So even in very planned and tidy and apparently non-fragmented systems, this is damn hard. But it is necessary to do. That's a problem we have with this thing. We have to do something which is damn hard. But that's what the challenge is. And actually, it's a very nice management challenge because it's probably the best management challenge I've seen in my career. It's much more interesting to be in this now than 30 years ago because of how interesting it is to make this change. Now, we all have the same problems, fragmentation, quality, etc. What we decided at the very beginning is to say if we stay in the same model, we're doomed. So we spent quite a bit of time for 3 or 4 months to say we've been throwing money at this thing called healthcare. It still is fragmented. It still has issues on quality. It still has a whole bunch of stuff on patient safety, and it's not improving. So let's not stay in the same model, otherwise we're doomed. This was even sort of before the crisis in the south of Europe. Actually, the crisis has just made dooming a bit quicker. But basically, we're still doomed even if there had not been a crisis, because the model is obviously wrong. Now, as I said, it's really the wrong time to be a minister. In my case, I was told I'm going to have the budget in 2009, 2010, 2011, 2012 of 2006, 2007 to meet the demand of 2012, 2011, etc. So even if without money, we decided to go for a transformation, as you see here. Now, so this is where I'm going to be talking at. So you have to free money from other things so that you can pull off the transformation because the transformation needs investment. But if you are in the lucky situation, which I think you are, from what I'm hearing today from Germany, is that you do have money, do it now. Don't wait to be here or here. We then therefore had to run 2 agendas at the same time as a minister, or we just had to run call it a resist culture, which basically you play around with salaries and pharmaceutical budget, and you get more generics, things like that. You disinvest in things that don't add clinical value, but basically you're just resisting. And the difficulty with just doing that for 4 years is that it doesn't change anything. You just please your Minister of Finance. But it doesn't change anything. Medicine just continues to be non-preventive, reactive, etc., not integrated and fragmented. So you have to launch at the same time a transformative culture, a transformative movement. That's what I'm going to do. So we launched in 2009. That's what I've been asked to talk about. So basically, we decided, it was called the strategy to meet the challenge of chronicity in the Basque region. The rest of Spain wasn't moving on this. Now it is. And just for you to know, at lander level, in Spain, at the regional level, we are very decentralized. So I decided to do all this without telling Madrid. Okay, I didn't tell the national minister I was doing this. I could have if that had been nice, but I knew I was going to be stopped, so I didn't. So we started moving, and I said, the general move is let's do much more at home, more in primary health care, and less in hospitals, because there was enough evidence, enough information to start that move. Evidence since then has been growing. We've seen a bit more from Juan. We'll hear a bit more later. But evidence has been growing since then, and that's the right general move. More in the community, less in hospitals. I'm sorry for those of you that work in hospitals, but the concept of sustainability, at least in our setting, is only possible if you do this move. The general trip that we have to, the journey that we have to do is to get out of this more reactive, acute, as you know, biomedical model towards the words that you've been using today, accountable, proactive, population health, and you have all the words here, people-centered, triple aim, more active patient, accountable care organizations, more efficiency, and payment for value and value. Now, what's interesting is that you have some parts of the world doing really interesting stuff at delivery level, but they're not accompanied by either the financing or the policy level. We in our university were studying a lot, well, what does the policy level actually have to do to help this level move forward? Because it is very difficult for this level, which is piloting and doing interesting things, to be sustainable in time with those changes unless you align the policy, the financing, and the delivery. I know that's common sense, but it doesn't happen. So you have a lot of places in the world blocked at pilots at the delivery level, doing very interesting things, and the political level is not putting in the energy it needs to put. More and more there is movement around here, of course. There's more and more laws, there's more and more regulations that are saying, I'm going to create conditions to be able to move to bundled payment, global payment, pay for value. I'm going to make much more better conditions to go towards a population health agenda. But there's still more an exception than a rule. This is how you feel as a Minister of Health, because just everything is just about against it. Everything in this move, the incentives have been where they are for the last 300 years. So to actually start that journey is of course very, very difficult. So we knew that, so we decided to use a lot of levers. Everything that we could dream of, most of it after looking at the evidence, but everything we could dream of, we pulled. Some of it was top-down, and some of it is bottom-up. Let me just very quickly go through all. Stratification is a top-down issue, or if you have an electronic medical record, it just has to be top-down over all your population. Other things, of course, about how to integrate care, how to empower patients, things that we didn't really know how to do, we leaned on local innovation. So this is pull stuff, and this is push stuff. Let me just quickly run through. So it means using all the frameworks that you know about, stratification, chronic care model, triple aim. As what's really interesting is now you have about 4 or 5 laws in Europe which are using these frameworks in the law as the launching framework, intellectual framework for the law. And we were leaning on those as well. We risk stratified. What's interesting about risk stratification in a population is that most of us do have the information systems to stratify. And actually in 2 years, we had the population in the Basque Country stratified. So we could start aiming the people with different types of interventions as we move forward. We built the electronic medical record. We, of course, played around with all the teles of the world, all types of telecare, telemedicine, tele-everything. It has a lot of difficulties because, as you know, many of these things, the technology is mature, but the organization is immature. So a lot of people who are here maybe working in tele things are probably suffering the same way we suffered, in the sense that we did not have, our organizations were not really ready in management and organizational terms to embed those technologies. So normally what we decided to do is to start, of course, helping organizations to mature much quicker so that they could embed those technologies. The EMR, a lot of integrated care, coordinated care experiences, patient empowerment, but all pilots, even if I was the king, okay? I was the minister over an organization of 26,000 people, and even in that tidy system, and putting all these instruments in place, all these interventions in place, it is still very difficult to get out of that piloting logic. We built electronic prescription systems, and we started playing around with the new payment approaches so that we could get into more bundled payment and global payment arrangements as we move forward. We did see, as we move forward during 4 years, and that's tracked and available on the web, let's say most of the big outcomes are visible in many of those pilot experiences, although we are getting very ambiguous results at reducing costs. We're having a lot of difficulty in the cost reduction because you have to invest, of course, up front before you see any return on investment on a lot of these things. But little by little, it's coming across, and all these things prove that it seems to be the right direction of movement. These are just specific examples of some of the pilots. This is one of the local integrated systems. You can see that fewer hospital admissions, less, et cetera, less visits, et cetera. And you can actually monetize and put a euro amount on some of the savings as you move forward in the system. The same thing with this other telecare experiences where with different, but again, there are pilot experience where you have a reduction in admissions of 27%, 2.5 shortest time. So anyways, a lot of these pilot experiences, and there are many of them in the Basque region, in other parts of Spain, in other parts of Europe, of course, are all showing pretty interesting results. But the big headache is the one-to-one. So one of the ways to move forward is to start creating an organization like the ACOs, the Accountable Care Organizations in the US, or like the ones I'll show after, care groups in Netherlands, et cetera, where you start reasoning in terms of a local system versus managing structure. This again is very hard because these organizations traditionally have not worked together, and they do not depend, of course, on the same administrative arrangement. Even if an NHS type of systems, more of these are under the same roof, that does not mean it is easy to make them work together. But I think it's very interesting that many countries that I'll really quickly show later are moving in some sort of local integrated system. Otherwise, you're not going to be able to pull off patient-centeredness, et cetera, we think. One final thing is, this is a very interesting study which you cannot pull most of these things off unless you have staff engagement. This study over these 14 hospitals in the UK is being repeated elsewhere, but basically is you get better patient satisfaction where you involve doctors more in organizational and management decisions. You get better quality of services where you involve doctors, nurses with a high involvement of staff in decisions in the hospital. You get better mortality. Okay, these things make sense, but you also get better financial management of the hospital, which I think is very interesting. So the more you engage staff, the more I don't know about you, but in Spain, we're not very good at engaging staff from the administration. We tend to try to do everything top down because we know better. I think that's why I said the speed of change will depend on how well one pulls this off. It will not depend on how fast the minister moves or introduces things or puts a law. Scalability, just to finish off then, is of course the key challenge. When I left, or when I was asked to leave, because we lost the elections, the issue was all those interventions that I mentioned, electronic medical record, risk stratification, patient empowerment, et cetera, were moving. There are more and more staff involved, But the key point is that we still had to address scalability. So in the last year, and now the present government continues, we think that the main, if one wants to go to scale, one has to take this to the policy level. One should not be continuously engaging providers to do pilot exercises unless the policy level truly believes this is the way forward. We address scalability by moving many levers, because if you only move, for example, like some people are doing patient self-education, don't expect a big change towards person-centered care. You have to move a lot of the levers in order to move forward. The new patient schemes will, based on value rather than activity, will push things forward. They're being played around with in Spain very actively, and of course in the US, some parts of Europe. Scalability will also come from identifying a model in that local integrated group which can share savings. In some parts of Europe, people are developing local integrated systems, loose or tight, but they do not, and they make economies and they make efficiencies, but they're not allowed to keep them. They go up to central budget. So I wouldn't expect that the second year that to continue unless you let some of the savings be kept at that level. And something that Juan Tello was mentioning, this logic of local innovation, we think is very important, and it has a lot to do with the issue of staff involvement. You need to get, of course, unlock the local health innovation from the staff and not do everything from the top. These are the words that people are using in different countries, but they're all the same thing. We're tracking them in the Basque, in the university. They're called different things in different countries, but they are all about organizing some sort of local system. There are many different types of them. Some of course have to organize a system of organizations that do not depend on the same top management group, which makes it a bit more difficult, but that is extendable, of course, to things that you're using. Thank you.